Good afternoon. A very warm welcome to this CGR from Department of Anaesthesiology, Pain Medicine and Critical Care. In this CGR, we are presenting our experience, anesthesia experience of TM joint ankylosis in pediatric patients. Though we are doing for decades, but over the years we have evolved ourselves, and this condition has a very unique challenges of airway management. So, but this time we are presenting our data of past 3.5 years. And now I invite Dr. Devalina to present to conduct the program.
So good afternoon, everyone. So our department has been closely associated with the Department of Oral and Maxillofacial Surgery for more than a few decades now. We both are responsible for each other's growth, right? And the Department of Radiology has also been very invaluable in their support in planning and management of these cases. Today, we will begin by discussing the anesthetic concerns in the pediatric patients with TMJ ankylosis. We will be joined by the Department of Radiodiagnosis and the Department of Oral and Maxillofacial Surgery in sharing their valuable insight in this case. May I call upon Dr. Leishni Agnes, Senior Resident from the Department of Anaesthesiology, Pain Medicine and Critical Care. She will be giving a brief introduction to the major concern, and the major concerns in the TMJ ankylosis patients. Dr. Leishni.
Thank you, ma'am, and good afternoon, everyone. I shall give a brief introduction as to what a TM joint ankylosis is and the areas of concern as an anesthesiologist. Temporomandibular joint ankylosis, it is defined as significant or complete limitation of movement of the TM joint due to bony or fibrous union of condylar head and glenoid fossa, which obliterates the normal articulation of the joint. The usual age of onset of TM joint ankylosis in children is below 10 years of age, which is concurrent with the active growth phase of early childhood. Children present with restricted mouth opening, dentofacial deformity, malocclusion, poor oral hygiene, difficulty in mastication, malnutrition. Patients with TM joint ankylosis often have micrognathia and retrognathia, and they have symptoms of obstructive sleep apnea. TM joint ankylosis usually results from injury in 13 to 100% of the cases. Local or systemic infection accounts to 10 to 40% of the cases, and systemic autoimmune diseases such as spondylitis, rheumatoid arthritis, and psoriasis accounts up to 10%. Cytotoxic medication, repeated TM joint surgery, and irradiation are the other causes. Literature shows more preponderance of TM joint ankylosis in females in the first and second decade of life, with trauma being the most common cause. As anesthesiologists, our main concern in these patients is the airway, both due to the nature of the diagnosis, where patients present with restricted mouth opening, making insertion of laryngoscope tube or airway adjuncts to the mouth difficult. In children with retrognathia or micrognathia and facial asymmetry, application of the mask for mask ventilation might be difficult. Pseudomacroglossia due to mandibular hypoplasia further decreases the airway. Another reason why airway in these patients is challenging is because of the pediatric age group. Children have anatomic and physiologic airway different than adults. Anatomically, the larynx is cephalate in position. As compared to an adult, an epiglottis is large and floppy. The tongue in children is larger in relation to the oral cavity, and adenotonsillar hypertrophy is present, which is more common in preschool children. If this is present, the prerequisite for insertion of a nasotracheal tube becomes challenging for fear of injury to adenoids. And physiologically, children have higher metabolic oxygen demand and lower functional residual capacity, leading to low oxygen reserve. Therefore, there is significant reduction in the time available for performing tracheal intubation and securing the airway in small children. The difficulty in intubation is also compounded in a child with TM joint ankylosis because of trismus and lack of cooperation from the children. Patients with TM joint ankylosis also have increased propensity for airway obstruction and obstructive sleep apnea. This is commonly associated in children with TM joint ankylosis, and it is characterized by partial or complete occlusion of the airway during sleep in spite of the respiratory efforts. The airway obstruction is mainly due to decrease in oral space in the oral cavity and encroachment of the oropharyngeal and hypopharyngeal lumen by tongue and soft tissues into the pharynx. This leads to disparity in gas exchange, resulting in hypoxemia, hypercapnia, sleep disturbances, daytime somnolence, and behavioral issues. The options for securing airway have evolved over time, with the first report of flexible bronchoscopic intubation being used in TM joint ankylosis for the first time in India in the year 1999. Blind nasal intubation used to be an option, but is no longer used due to availability of advanced airway equipment now. And also the risk of blind nasal intubation outweighs the safety in children, as complications like bleeding, if they occur, can lead to aspiration and bronchospasm, which threatens the airway further. Retrograde tracheal intubation is difficult to perform and is rarely applied to children. Flexible bronchoscopic intubation would be the option of choice owing to the absence of mouth opening. Tracheostomy is reserved for patients with associated comorbidities, and it is an invasive procedure. Flexible bronchoscopic intubation can be done awake with regional blocks, nebulization of the airway with local anesthetics or topical anesthesia. Sedation is also used with intravenous or inhalational agents. Flexible bronchoscopy can also be done in a patient on spontaneous respiration or with the patient paralyzed. Awake flexible bronchoscopic intubation is the gold standard, but it is not feasible in children. We have guidelines for anticipated difficult airway given by Difficult Airway Society and Association of Pediatric Anesthetists. DAS guidelines have given us algorithm to manage difficult mask ventilation, where according to the algorithm, if mask ventilation is difficult, then optimization of head position with chin lift and jaw thrust is advised in the first step, which is not feasible for us. Also in the next step, if back and mask ventilation is still not possible with optimization of head position by adjusting the chin lift and giving jaw thrust, they have advised us to move to step B, where they have advised for insertion of oropharyngeal airway, which is also not feasible for us in these children as they do not have mouth opening. Also, they have advised that if it is still not feasible, if back and mask ventilation is still not possible with insertion of the oropharyngeal airway, step C advises for an insertion of a supraglottic airway device, which is also not feasible for us in these children. Thank you. This was a brief introduction to how we have concerns in children with TM joint ankylosis. Next, I would like to call upon my colleague, Dr. Sarah, to present the data of our institute.
Thank you, Dr. Deshne. Now I would be good evening to all present here. Now I will be presenting our departmental data regarding pediatric TMJ ankylosis. The cases were taken from January 2022 to June 2025 over the period of last 3.5 years. We were able to identify 70 patients, of which 13 patients were excluded because 7 patients were admitted, but in those 7 patients, the surgery was referred. And in the 6 patients, there were incomplete documents, including missing PAC documents, anesthesia chart, or intraoperative details. In the demographic details of our patients, we found that the majority of our patients were in the age group between 6 to 15 years, and the youngest was of a 3-year-old male patient. We had 30 males and 27 females in our population. The American Society of Anaesthesiology Physical Status Classification for perioperative risk stratification was done on our patients based on the severity of OSA and presence of other systemic illness. Out of the 57 patients, 12 patients were in the class ASA 3, denoting the higher perioperative risk in this group. The other systemic illnesses that was being noted were 3 patients with neurological disorders, including global developmental delay and febrile seizures, and 3 patients with juvenile idiopathic arthritis. The major etiology for pediatric TMJ ankylosis was found to be traumatic in 61.4%, followed by idiopathic causes in 24.5%, and along with smaller percentage due to infective and inflammatory etiologies. Seeing for the joint affected by the TMJ disorder, we had 35 unilateral cases and 22 bilateral cases. And of the 57 patients, we had 9 patients with recurrent disease. We found that in the age group less than 5 years, the idiopathic causes were more common as compared to age group more than 5 years, where the traumatic causes were more prevalent. The major systemic sequelae of a pediatric TMJ ankylosis is the development of obstructive sleep apnea due to inadequate growth of the mandible, leading to overcrowding of the soft tissue, later resulting in airway obstruction. Sleep study is required for the diagnosis of OSA, but majority of our patients did not undergo this investigation. We have classified them based on the severity of symptoms into snoring only and snoring with added symptoms like daytime sleepiness, nighttime awakening, bed wetting, and poor scholastic performance. Of the 57 patients, we had 34 patients with symptoms suggestive of OSA and in 12 patients with suggestive of severe OSA. On comparing the time period between the index presentation and onset of the disease, the later is the presentation of the patient to the for treatment, more is incidence and the severity of OSA. Also, similarly comparing the incidence of retrognathia with etiology, we found that idiopathic causes have more occurrence of retrognathia due to early onset of disease and also maybe due to absence of a preceding event before the development of disease. Comparing the time period between the onset of disease and the index presentation, later is the presentation, more is the degree of retrognathia present. The mouth opening or interincisor gap in a normal individual is more than 30 mm, and majority of our patients had nil to less than 5 mm mouth opening, making a conventional laryngoscopy or even a radiolaryngoscopy impossible. Coming to the surgeries patients have undergone, majority of the patients had undergone TMJ reconstruction. A few of them had undergone disc replacement, and in 4 patients, TMJ joint replacement was done. Of 57 patients, in 38 patients, the airway was secured after giving a neuromuscular agent, and only 19 patients, the airway was secured wherein the patient was maintaining the spontaneous respiratory efforts. The technique of achieving a definitive airway placement was a flexible bronchoscope in 94.7 patients, and only in 5 patients was it with a video laryngoscope. For the technique of anesthesia maintenance, the agent of choice for anesthesia maintenance was chosen after seeing for the requirement of intraoperative nerve monitoring. If intraoperative nerve monitoring was required, then we were opting for total intravenous anesthesia, which was required in 26 patients of the 57. And if it was not required, the agent of choice was inhalation agents. There was no any major anesthetic complications seen in our patients, such as requirement of a tracheostomy or abandonment of procedure due to inability to secure the airway. However, 2 patients had surgical complication. In one, where the patient had uncontrollable bleeding and was later shifted to a radiologic intervention, but which was not required, and patient was fully extubated later in the OR. And one of the child required intraoperative blood transfusion due to major loss. All patients were extubated fully awake. 2 patients had delayed awakening and later were extubated awake in the recovery. No patient had requirement of postoperative ICU or HDU stay. 4 patients had postoperative airway obstruction, which was managed by the insertion of a nasopharyngeal airway. Elective placement of nasopharyngeal airway was done in 10 patients. There were no events of mortality or morbidity was noted during this period of study. Looking at the association of the obstructive sleep apnea with the postoperative nasopharyngeal airway placement, if us anesthetists suspect a patient is going to have any kind of high risk of airway obstruction in the postoperative period, prior to extubation, we usually put a nasopharyngeal airway. So comparing the patients with the symptoms of OSA and the requirement of nasopharyngeal airway, we found after 34 patients out of 57 who had OSA, snoring only group had only 9.5% requirement of an elective placement as compared to 65.5% of patients, denoting the risk of obstructive symptoms in the postoperative period. Now I've come to the conclusion of the data presentation. Now may I invite Dr. Monica SR from Radio Diagnosis to give us insight regarding the radiological intervention as well as imaging in these kind of group of children.
So, I will highlight the role of CT imaging in TMJ ankylosis. So, CT plays a very critical role in TMJ ankylosis. So, the key points which we're going to discuss today are ankylotic chunk measurement, the quality of the bone, in the glenoid fossa and its pneumatization, proximity to the vessels and the role of pre-operative and the post-operative embolization, and proximity to the external acoustic meatus. So the ankylotic chunk measurement is done in all the three planes, the mediolateral, supero-inferior and the antero-posterior. So in the first image, here is the axial section which is taken and the mediolateral dimension is taken. The second is the coronal view and here the superior-inferior dimension is taken, and the third picture here is of the sagittal view, and here the antero-posterior dimension is taken. So the relationship of the ankylotic chunk with the vital structures. So what are the vital structures that we should discuss? First is the internal maxillary artery, then the distance from the inferior alveolar nerve canal opening, the lateral pterygoid plate, EAC, and the skull base assessment. So the distance from the IMA is taken on the coronal view. Here, as we could see, this is the distance of the ankylotic chunk from the IMA. So this case is from the department itself, 18-year-old girl, and the distance was less than 3 mm. So this less than 3 mm is a reduced distance of the IMA, and it's very critical for the operative case. Then now we will discuss the distance. How do we measure the distance of the ankylotic chunk from the inferior alveolar nerve canal opening? So this here is the coronal view. As we could see, this is a normal patient, and the distance is increased from the normal TMJ to the canal opening. This is a case of early fibrosis, and the distance is reduced here, and it is further reduced in the cases of advanced ankylosis to almost around 5 mm. Now, another structure that we have to see, the lateral pterygoid plate. So this is the lateral pterygoid plate, and this is how we measure the distance. It is again taken on the coronal plane, and this is the early stage ankylosis. The distance is reduced, and further this is the advanced stage in which the distance is further reduced. We also need to measure the distance between the external auditory canal and the ankylotic chunk. So this is a normal case here, and in this case there is severe ankylosis, and the distance again is reduced. So these all structures could be injured during the surgery, so we need to really take care of them and assess them before the surgery. So the skull base assessment. So the slide here shows the normal structures. See, this is the condylar head, the glenoid fossa, foramen ovale, this foramen spinosum. So the foramen ovale and the spinosum, they lie medial to the TMJ, and the carotid canal and the jugular foramen, they lie posteromedial to the TMJ. So this is the normal anatomy. Now here, as we see, so there's some separation is seen between the two, the foramen ovale, spinosum, and the TMJ. In this case, as we see the late stage, there is further reduction in the separation between the ankylotic chunk and the vital structures from the foramen ovale. So again, further the later on stages, again there is reduced separation between the two. Here in this slide also we show the pneumatized air cells which we need to see, the pneumatized mastoid cells. So we also need to assess for the mastoid bone whether it is involved or not. In this case, as we could see, the mastoid air cells are complete, the mastoid bone is completely involved by the ankylosis. This is the VRT image showing the same, the mastoid involvement. This was also the same case, the previous case which we had taken, an 18-year-old girl with severe left-sided ankylosis showing the mastoid bone involvement. So we also need to measure the height of the ramus and the coronoid process. So the height of the ramus is taken along its posterior margin like this, and in the region of the deepest antegonial notch like this. And the coronoid process length is taken corresponding to a distance from the tip of the coronoid process to the mandibular incisor. Very critical is the airway assessment. The same case, we had seen that the airway is stenosed here. So in case of TMJ ankylosis, we also see in these patients that the airway also appears to be stenosed. So now I shall invite Dr. Garima to come over and give her surgical insight.
Thank you, Dr. Monica. And now I will discuss the surgical aspects of the pediatric temporomandibular joint ankylosis. As we can see in TMJ ankylosis, there is fusion of mandibular condyle with the glenoid fossa that often leads to limited mandibular function, and it also affects the growth in pediatric patient, causing the facial asymmetry, and in severe cases, it causes obstructive sleep apnea. So goals of treatment should focus on the restoration of mouth opening, joint function, allow for the condylar growth, correction of the facial profile, and release the upper airway obstruction. And the treatment outcomes should include function, growth, and aesthetics. So let's have a look at the different treatment options available. The simple is interposition arthroplasty, in which after the removal of the ankylotic mass, we interpose either with a buccal fat pad or abdominal fat pad. It will address the function, however, it will not address the growth. To address the growth, we need to reconstruct the ramus condyle unit, for which we can either go ahead with the costochondral graft, in which the costal cartilage is transplanted into the mandible to address the growth. However, in recurrent cases, the graft uptake is unpredictable, so we can go with transport disc distraction osteogenesis. And recently, alloplastic prosthesis has been done in pediatric population. So what happens in TMJ ankylosis with obstructive sleep apnea? If we release the TMJ ankylosis with or without reconstruction, it will not address the respiratory distress caused due to obstructive sleep apnea. So we should go ahead with the distraction of the mandible first to address the sleep apnea. And this is a departmental study in which pre and post distraction AHI were compared and found that the distraction osteogenesis significantly benefit the patient from OSC. Now let's have a look at this case of 5-year-old female complains of snoring and difficulty in sleeping. On profile, we had chose convex profile, severe heterogenia, reduced high mental distance with a nil mouth opening. And the radiograph shows bilateral TMJ ankylosis.
and the lateral cephalogram showing significant narrowing of the airway. CT images showing bilateral TMJ ankylosis and the enlarged coronoid process. So we plan to distract the mandible first, for which we make patient-specific cutting guide to have the desired vector for distraction. These are the intraoperative photographs showing the osteotomy lines in situ. And there is the post-operative clinical picture of the patient showing 3D distractor in position. And this is the picture in which post-distraction we can see a significant improvement in the lower third part of the face. And the lateral ceph also demonstrates the significant improvement in the airway. Second stage was addressed by doing osteoatherectomy and ramus condyle unit reconstruction with costochondral graft. This is the 1 year follow-up of the patient, and we all can see the aesthetics is maintained, the function is achieved. Growth is also maintained in the follow-up period, and cephalogram also shows the maintained airway in the follow-up time. And the orthopantomogram shows the neocondyle formation at the right TMJ region. And this is a departmental study in which we see that the patients underwent costochondral graft to maintain the functional matrix, and growth of the mandible is achieved. So CCG fulfills the reconstructive goal in children and is considered as gold standard treatment in pediatric TMJ ankylosis. This is another departmental study in which we compare the transport disc distraction osteogenesis and the costochondral graft, and we found that both the treatment modalities resulted in improvement in the function, growth, and aesthetics of the patients. Now, what if autogenous graft failed? So, Sidebottom in 2013 suggested the use of alloplastic total temporomandibular joint replacements in children, especially in cases where autogenous tissues have previously failed. Functional matrix theory explained the continued growth in the pediatric patients. And Mercury and Swift also demonstrate the successful outcome in the range of motion and occlusion without any signs of recurrence. So far, we have done 4 patients in pediatric TMJ ankylosis with alloplastic prosthesis. So let's have a look at this case. A 14-year-old female complains of snoring and difficulty sleeping since 4 to 5 years. And profile view again shows the convex profile, retrogenia, reduced himental distance and nil mouth opening. The radiograph shows bilateral TMJ ankylosis. And the lateral ceph shows significant narrowing of the airway. So we, as usual, we distract the mandible first, and post 14.5 mm of distraction, there is a significant improvement in the airway. These are the clinical profile view, which showing the improvement in the lower third part of the face. And second stage was addressed using alloplastic total temporomandibular joint replacement. This is the cutting guide and the images of the implants. And these are the intraoperative pictures showing the fossa, this one image, and the mandible component in position. And this 1 year follow-up of the patient. The function is fine, and the aesthetics is also fine. And there are post-operative radiographs showing prosthesis in position, and patient is doing fine. As with any TMJ surgery, complications are there. So is with the TMJ ankylosis, and one of the complication is recurrence. As we can see in this radiograph, costochondral graft was placed a year ago, and the patient again came back with a complaint of reduced mouth opening, and we can see a bone here. Now, what are the reasons for recurrence? It may be due to excessive bone formation or inadequate removal of the ankylotic bone, especially this medial part, and non-compliance for physiotherapy. So we have strategies to reduce re-ankylosis in the temporomandibular joint ankylosis patients, in which we should completely remove the ankylotic mass, particularly on the medial side, and use a piezoelectric scalpel for clean and smooth osteotomy and to have a minimal debris in the surgical site, and fat interposition that change the osteogenic environment to the lipogenic environment, and the vacuum drain to prevent the dead space. However, in the post-operative period, active physiotherapy plays a vital role in preventing recurrence. When combined with the good analgesic, patient compliance is more for the exercises, and our department protocol include the use of trismus screw, and this time frame shows so far we have seen no recurrence by following this protocol strictly. Then the alloplastic prosthesis is a gold standard in the adult patients with minimal complications. The major concern with the alloplastic prosthesis is the risk of metal ion leaching. Our departmental study on adult patients showed that titanium ion level rise over a 3-year period time, after which they attain the steady state. However, studies are awaited for the pediatric patients, and we are routinely following these patients and have regular follow-ups. And this is the table. This slide shows the treatment procedures done over last 3 years in the pediatric population, and the most commonly used treatment modality is costochondral graft, and distraction is routinely being done in cases with obstructive sleep apnea to address the respiratory distress first, followed by the function, aesthetics, and growth. Thank you. And now I would like to call upon Dr. Abhishek, Associate Professor, Department of Anaesthesiology, to discuss the anesthetic management of the TMJ ankylosis.
Thank you, Dr. Garima. I will be giving a brief overview of the anesthetic management of TMJ ankylosis surgery. The airway management in these children is challenging due to factors like poor cooperation, severely limited mouth opening, mandibular hypoplasia, and retrognathia. Many of these patients have OSA and an increased risk of hypoxia and bradycardia. Post-op airway compromise remains a significant concern, necessitating vigilant monitoring. So the anesthetic management can be broadly discussed under three headings: pre-operative period, intraoperative, and the post-operative period. So in the pre-operative period, we begin by eliciting a detailed history by understanding the onset of symptoms, whether it has started from childhood or it has developed over a period of time. It is important to assess the activity level of the child. A reduced activity or fatigue in a child with OSA, with TMJ ankylosis usually says the patient may be having chronic hypoxia or poor sleep quality. Features suggestive of OSA, such as snoring, frequent awakenings, or disturbed sleep, somnolence, they suggest severity of the disease. Asking the position of the patient, how the baby sleeps, how the child sleeps, gives again we'll get to know about the severity of the disease. Finally, we should also look for certain symptomatic associations, if any. This is followed by a detailed airway examination, assessing for mouth opening, interincisor distance, submandibular compliance, mandibular protrusion, nasal patency, range of movements, etc. Relevant investigations are sought and informed parental consent with assent is taken. Inside the OT, a team meeting with all the concerned personnel such as anesthesiologists, surgeons, OT technology, other supportive staff are usually we start before taking the case in the OT. Difficult airway equipment cart or setup is arranged. Commonly used equipment such as fiber optic bronchoscope, video laryngoscope, nasopharyngeal airways, and ETT are selected according to the size of the patient. So they are individualized. Other equipment such as the suction device, supraglottic airway device, surgical airway kits, they are kept ready as per the requirement. In the intraoperative period, we have 5 phases: pre-medication, induction of anesthesia, airway management, maintenance, and tracheal extubation. We use antisyllagogues such as glycopyrrolate to reduce or decrease airway secretions, especially in patients who are breathing spontaneously. Anxiolytic agents are used according to the anesthesiologist's comfort and expertise, and usually avoided in patients with OSA. Topicalization of the upper airway is done in patients where awake intubation is considered. The next phase is induction of anesthesia and the airway management. Here we have a major dilemma, whether we should induce the patient and then secure the airway, or whether we want to secure the airway first and then go for induction. So there are 3 options over here. The first option is we secure the airway, then give some sedation and give muscle relaxant accordingly. The second, in the first option, the patient is completely awake and they are following our commands. The second option, we give some sedation, some sort of sedation to the patient so that the patient is sleeping but breathing spontaneously. Then we do the airway management and then followed by muscle relaxation. And the third option is giving complete general anesthesia along with muscle relaxation. When the patient is completely under, then we secure the airway. Okay, so the first 2 options is where the patient is breathing spontaneously, either awake or under sedation. Where the third option is with muscle relaxation. So currently, the definitive airway management for such patients is flexible bronchoscope guided nasal intubation. So now let's have a look at the airway management in one of these patients. So this is a 14-year-old child. She has been given sedation. Patient is breathing spontaneously, and we are planning to do a nasotracheal intubation. Okay, so the fiber optic bronchoscope is inserted in the right side on the right nostril, and in the left nostril we have nasopharyngeal airway, which is connected to the circuit. So para-oxygenation is going on. So if we can observe closely now, we can see the trans illumination. So that means the tip is in the near the larynx now. So we guide the fiber optic bronchoscope into the trachea and then reach the carina. Once we are reached the carina, we will start railroading or moving the endotracheal tube on top of the fiber optic bronchoscope. So before we do it, we have to adequately make it fluid. That means we apply jelly and then make sure it goes without any obstruction. Okay, after the endotracheal tube is railroaded over the fiber optic bronchoscope, we take it out and then confirm. So we'll see the fiber optic tube, what the anesthesiologist is seeing at this point of time. Here, what we were doing is, we were just looking from the third perspective. What the anesthesiologist is seeing, we'll have a small video. Okay, this is the same patient. As soon as we enter the oropharynx, then we go down, we see epiglottis, we see the vocal cords, we see the trachea, and this is a catheter which has been placed to anesthetize the vocal cord area. Okay, after that is done, we start going inside. Since the patient is spontaneously breathing, slight movement may be there depending upon our block, depending upon the topicalization of the airway. Okay, so after that, we can identify the tracheal rings. And once we reach the carina, we stop the movement, railroad the endotracheal tube, visualize the endotracheal tube at just above the carina, and then take the fiber optic bronchoscope outside. Okay, now we are able to see the carina. Now there is endotracheal tube. Now we take out the bronchoscope. So here is a common example problem which occurs in spontaneously breathing patients, especially when there is vocal cord movement. If airway, the topicalization has not been done properly, a vocal cord will try to close. It is a protective mechanism. It will try to close and prevent further movement inside the trachea. So we can see it is completely closed now. It will take some time for it to open. So we have to anesthetize the airway by giving adequate amount of time for it to act. So after that, in the next video, I'll show you. Here, the patient has received muscle relaxant, general anesthesia followed by muscle relaxant. Now we are trying to go. That problem is taken care of. However, we have to do the risk-benefit analysis in choosing which patient will receive anesthesia first, followed by intubation. Okay, so in the maintenance phase, anesthesia is maintained using either inhalational or intravenous agents. Analgesia is covered by opioids, fentanyl, and paracetamol. Tracheal extubation is done only when patient is completely awake. An airway extent catheter can be used in cases where extubation is considered risky. This is an airway extent catheter. By the end of the surgery, when we see that patient is breathing spontaneously, following commands, we want to extubate the patient. So we put this airway extent catheter inside the tube, and then once it has reached the carina, we'll take just how we inserted the endotracheal tube, we just take it out by keeping this in situ. And this is a long tube, so we can keep it at a safe distance. And after that, if required, if the re-intubation is required, this can be used as a conduit for re-intubation. In the postoperative period, antibiotics are given as required. Steroids are given to reduce the airway edema. patient is then shifted to the PACU for observation. ICU beds, we have not required ICU bed till now, but it will be requested as and when required. So to summarize, in the preoperative phase, a thorough history. In the intraoperative phase, depends upon the patient condition, and in the postoperative phase, we extubate once fully awake. So thank you very much. I call upon Professor Devlina to present the scientific literature and current practices on TMJ ankylosis.
So good afternoon, everyone, once again. I'll briefly take you through the scientific literature that is available on the anesthetic management of TMJ ankylosis. So one of the earliest report was published in the Indian Journal of Anaesthesia in the year 1999, which they had mentioned about experience of fiber optic nasal intubation for temporomandibular joint ankylosis. Here for the children, they had included about 25 cases. And the children, they all received general anesthesia in the form of ketamine, which is actually sedation, and 2% of lignocaine spray was used to topicalize the airway structure so as to place the airway, so as to place the endotracheal tube. This is another case report where they have tried anesthetic technique in 15 pediatric patients with temporomandibular joint ankylosis. This is from another part of our country. Here, this was in 2001. Here they used ether and halothane and spontaneous ventilation for the placement of an airway, for the placement of an endotracheal tube. Here they did not use a fiber optic bronchoscope. They had used a fiber optic light source to identify the tracheal opening. Very interesting case from our department, which was published in 2006. And around this time, fiber optic bronchoscope was not readily available. So they used a gum elastic bougie, which has an atraumatic tip, to place in the trachea first, followed by endotracheal intubation. And all the three cases they had the success rate at the very first stage. They had put one more endotracheal tube to block the esophagus. So when they put the gum elastic bougie, so it had only one passage to go, and that was the trachea. So the various other authors have also tried in different ways to secure the airway. Like one of them is they have used adult fiber optic scope to place in one of the nostril so that they can visualize the tube, a smaller tube going into the trachea. And one of the authors used fluoroscopic assisted airway intubation with the C-arm guided technique and observing. There are various research articles available in the anesthetic management. So this article has 5-year audit of a university hospital where they had, out of 32 patients, they had 16 patients. And for a fiber optic bronchoscopy was a choice for intubation. They had 2 failed intubations, and tracheal extubation here was done in the postoperative care unit after sufficient time had elapsed of giving anesthesia. Another retrospective review of 48 cases. This case series had more of blind nasal intubation than that of fiber optic intubation, probably due to the unavailability of the adequate size scope here. So they have kept blind nasal intubation as an alternative for securing the airway. This review of intubation techniques talks about awake fiber optic intubation as the gold standard. However, when areas where blind nasal intubation, where fiber optic is not available, they have advised blind nasal intubation, and also they have mentioned about the promising alternatives of retrograde intubation and light vent intubation. More recent retrospective case series where they have used more newer drugs like dexmedetomidine, midazolam, sevoflurane, and they have secured the airway while the child was breathing spontaneously. And here we find the use of adjunct to deliver oxygen. The adjunct was nasopharyngeal airway. So all these articles that I have discussed, they have mentioned about securing the airway, anesthetizing the patient, but the patient was spontaneously breathing. But where we do, this is one randomized control trial of using dexmedetomidine as a pre-medication in the OT with a loading dose, and then securing the airway. Like how was our institute practicing anesthesia for securing the airway or managing in these cases all this. This is a retrospective review from our institute. It has about 375 patients, and this was it. It covered the area from 2008 to 2018. So what were the main differences, or were we doing the same as the others? So the most preferred technique at our institute was anesthetizing the patient with either inhalational or intravenous induction, followed by administering muscle relaxant before securing the airway with fiber optic guided intubation. The maintenance of anesthesia was mostly with desflurane, and for the post-op analgesia, fentanyl was used over morphine. Now we are deviating from the international guidelines. We are also deviating from the major how others are doing it by the use of muscle relaxant. Now there's no other study to validate our our practice. So before that, we have seen here that the airway related events in the series, the majority of the airway related events occurred in patients like the difficult mass ventilation or difficult intubation, or the amount of desaturation in the patients who have had obstructive sleep apnea. It was considerably lesser in the patients who did not have obstructive sleep apnea. Now, to validate our practice of using muscle relaxant before placing the endotracheal tube, so we carried out a randomized control trial by comparing spontaneous breathing versus paralyzed technique with the flexible bronchoscope in children and adolescents having temporomandibular joint ankylosis. Here we can say that the paralyzed group had lower incidence of difficult intubation, they had lower time to intubation, and also the paralyzed group had lesser amount of complications than the spontaneous group. The one which is very ironical here is, the amount of desaturation. When we actually think, then the spontaneous group would be having less of desaturation than the paralyzed group. We had more in the spontaneous group, probably because the way Abhishek had shown that in the spontaneous group there is more laryngospasm. And the drop of SpO2 was up to 56% in the 56% in one of the patients, whereas in the paralyzed group, it was just 90%. This group of patients also require a modification of the analgesic technique to maintain their post-operative period, because they also go for physiotherapy. There's considerable pain. So we tried to find out if there is a way to increase. We have been regularly using infiltration technique post-surgery in the temporomandibular joint surgery. Now we added clonidine and dexamethasone to the local anesthetic. We found an increase in 4 to 5 hours adding this analgesic, and additional advantage that we got was decrease in the incidence of post-operative nausea and vomiting. So that was about the literature, and we have evolved over time. We have started using more advanced devices for the safety of the patient. One of them is the TRIVE, or the transnasal humidified rapid insufflation ventilatory exchange. This device is specifically designed for apneic oxygenation and ventilation. So this has increased the safe apnea time to about 20 to 25 minutes. This advantage allows us to teach our residents the skill of intubation in difficult airways. Before that, we were very apprehensive of giving this in very difficult cases, but we are able to give them now. One more thing is, because our patients very often have OSA, we have started using transcutaneous carbon dioxide monitor to see their carbon dioxide status while we are doing the intubation. We have also moved on to safer anesthesia techniques like total intravenous anesthesia. The use of nitrous oxide is very less in our OT, and we have completely done away with the use of desflurane because it's highly environmentally toxic. So this is where we began. We had initially our department was using red rubber tube for nasotracheal intubation. It was now we have moved on to using preformed tubes, and this is how we fix the preformed tube, because it keeps the airways, the surgical field away from the endotracheal tube. Good for them and good for us. From blind nasal intubation, we have moved on to flexible bronchoscopes and video laryngoscopes. Also, our monitoring is more advanced now. And from para-oxygenation, nasopharyngeal airway, we have moved on to the Thrive. So I thank all of you who are present here. I thank the Department of Radiology and the Department of Maxillofacial Surgery once again. And before I sign off, we have been talking about the flexible fiber optic bronchoscope all the while, but I'd like to give a brief tribute to the man, probably we do not know, he's our own countryman, an Indian-American physicist, Narinder Singh Kaplani, who is known as the man who could bend light. And he invented the fiber optics in the year 1953, and he coined the term fiber optics in 1960, and he was conferred the Padma Vibhushan in 2021. And he's also listed as one of the unsung heroes of the 20th century by the Fortune magazines, one of the 7 unsung heroes of 20th century. Thank you so much.
Thank you, Dr. Devina, and all the speakers. I just invite any question and comments from audience. Dr. Onkile, want to say something?
First of all, I congratulate the presenter who has presented very nicely. Secondly, I would like to thank from the oral investigation surgery to the anesthesia team for taking care of our patient, without which we are not able to, we will not be able to do the surgery and treat the patient. And the TMJ and the combination of TMJ ankylosis and whereas in a pediatric patient, I think it's the combo, and it makes the airway very difficult to manage. So, because of your expertise in the securing the airway during the surgery, pre-op, post-op, and the intra-op, we are able to manage without compromising the patient's safety. So thank you very much, and thank you, and keep this work ahead, and thank you.
Thank you, Dr. Ankila. Your words that encourage all of us, being anesthesiologists. Anyone else if you want to comment on this? Yep.
I just wanted to know the PSC. Is there any correlation between scanning PSC scan or X-ray you have? What is the experience you have or in other words, is it important to review the scan during PSC?
I don't think it's a regular practice with us to scan to review the scan. We are more correlating with the external parameters and the presence of the symptoms of obstructive sleep apnea for planning our intubation technique, and also for the ventilatory management and the post-op care.
So one of my query, patient comes some years or later than that for any other surgery after correction of TM1 joint ankylosis. Does it has a similar difficulty of intubation, or is there some?
Once the mouth opening is achieved, it is very wrong to assume that the patient can be handled with a simple direct laryngoscope or even a video laryngoscope. We have a habit of doing the Malampati score, Malam mouth opening. Very often, even the corrected, when even after correction of the mandibular setback or correction, the genioplasty, when it is what happens when temporomandibular joint, the onset is at a very early stage and the treatment is delayed. What happens? The muscles in the lower suprahyoid muscles they have not grown with age. It's only the bony structure which is, but it pulls up the larynx. So it's very unlikely for us, majority of the times, it's unlikely for us to have a glottic view, or sometimes we don't even see the epiglottis. So always have the fiber optic ready, flexible bronchoscopes.
Thank you. Just for information, we have started here the blind nasal when the dental center was not formed, and OT6 was designated for this ortho dental surgery. So halothane was used for spontaneous ventilation and for blind nasal intubation. In fiber optic, we adopted very late, sometime I think 2005, even beyond that. And despite that, even that we got only adult one. So in the pediatric case, still the blind technique was practiced. And I personally did blind nasal intubation with the ether. So ether I find the very safest method because it's a very wide safety margin. So, but the only problem with ether is because of cautery, and patients' recovery is very delayed. So for sometime 2 days, 3 days, patients used to be sleepy. वो जैसे मूवी में देखते हैं ना होश कब आया बोलते जी वो 4 दिन बाद होश आया. So it was the effect of ether anesthesia. And slowly we evolved when we adopted a bronchoscopic. Now the things has been very difficult, very safe and easy. And Dr. Debrina is doing a very good job at Dental Center, and many of our anesthesia colleagues were getting posting in the dental surgeon. Thank you so much for patiently listening.